Good evening and welcome to our webinar hosted by the San Mateo County Dental Society. It looks like we have a great audience joining us tonight. My name is Ben Yount and I'm your 2020 president. Before we get started, I want to review how we'll be running this meeting. All participants will be placed on mute. Our presenter will provide a presentation on the falling wall between medicine and dentistry. During the presentation, you may post a question into the question and answer box. For those on your desktop, the question and answer box is located at the bottom of your screen. For those on an iPad or iPhone, the question and answer box is on the upper right. Please feel free to post your questions. And I just got word tonight that I'll be asking the questions to our speaker in real time, so that'll be great. So tonight, our presenter is Dr. George Maranon. Dr. Maranon is a board-certified maxillofacial surgeon and has been practicing his specialty in the San Fernando Valley since 1993. He earned his bachelor's degree from UCLA and dental degree from the UCLA School of Dentistry. Dr. Maranon completed his oral maxillofacial surgery residency at the Westchester County Medical Center and served as chief resident in 1991. He went on to earn his medical degree from the New York Medical College in 1993. Dr. Maranon is a diplomat of the American Board of Oral and Maxillofacial Surgeons. So without further ado, Dr. Maranon. Now.
Yeah, I want to thank I want to start off my meeting with thank yous. Thank yous are oftentimes in these kind of talks left until the end of the meeting. I'd actually like to start off with the thank yous. The first thank you is for Ms. Manfredi and WEO Media. Not only it sounds like they're committed to servicing you and your practices and online service, but it also shows their commitment to dentistry. I want to do a special thanks for Nakia and her staff and Jim as well, who was on a call with me last night at 6:30 in the evening to make sure that everything went well for today. So Nakia and your staff, thank you very much for this. And Ben, thank you for asking me to participate. I also want to thank your trustee. Your trustee is Carliza Marcos. As you know, the new secretary for CDA. So let's talk a little bit about what I mean by the falling wall between medicine and dentistry. Okay, let me go back one slide here. All right, so I need to tell you that practicing dentistry is a lot different than it was a few years ago. There's been advances in medical science and they're coming through exponentially. Not only do we have heart valve replacement, we also have organ transplantation. There's improved outcomes from malignancies and immune deficiencies, and patients are now on multiple medications. We now have elderly people living longer, and they're surviving conditions that previously would have been fatal. I like to tell you about a story of one of my patients who came in for implants, and he was 99 years old. And so we had him scheduled for implants, and he decided to cancel his appointment. And when we asked him about why he was canceling his appointment, he goes, "Well, I'm not canceling it, I'm just postponing it. I'm actually having my eyes done because they make me look too old, and I'll be back to do my implants later." And we subsequently did his implants. All right. In dentistry now, it's not just doing a DO onlay on tooth number 19. We actually have to do a medical assessment. And I just want to introduce you to a patient. This is Mrs. Barnes. She's a 65-year-old female who frequently does Botox for frown lines. These are the supplements that this is just from my office. These are the supplements that she brought in because she wanted to make sure that they were all safe with me. She's a gym rat, and she refuses to accept her age. All right, so when I talked about risk assessment, we need to actually go back to the medical model. So we normally start off with chief complaint and then history of present illness. But when we start to think about medicine, we need to think about their medical history as well. So what medical problems do they have? What medications are they on? What's their past surgical history? Do they have any allergies? What are their social histories? And when I look at this, I think about a patient that I had who filled out his medical history form, and in questioning him, I was kind of looking through his medications, and he's on all these anti-rejection medications. And I look at his medical history, and it's basically all of them are no's. And so I started to go through a review of systems, and I asked him, do you have any heart problems? And he goes, no, not since I had my heart transplant. So patients oftentimes don't appreciate the importance of their medical history when it affects dentistry. In terms of physical examination, one of the things you want to do is just take a look at the person. Is this person someone that looks healthy, someone that doesn't look healthy, or is it someone that you wish you looked like? You also want to assess their vital signs. What's their blood pressure? You want to actually put your finger on their pulse just to see what their pulse feels like. You want to watch their breathing. So all of those things are important in terms of developing a general assessment for your patient. So there are some indicators that you can use to assess patients. One of them is body mass index. And basically body mass index is you take your height in centimeters and you divide it by, you take your weight in kilograms and you divide it by your height in meters squared. And that's the formula. But there are also these tables that you can get, and they're available online. And they actually give you an idea of what is the body mass index. And the body mass index is useful in screening for other possible health problems that an individual might have. And so when I looked at this, I kind of figured it out, and that's when I decided to call Jenny Craig. We also have help from our medical colleagues. The American Society of Anesthesiologists actually came up with their own classification for risk assessment. It's called the ASA classification, and ASA 1 stands for a normal, healthy patient. I'm not sure if this patient really exists. They're healthy, non-smoking, and of course, no or minimal alcohol use. ASA 2 patients are what we predominantly see in our practices. That would be a patient with one or more mild systemic diseases, but they're not someone who those diseases cause functional limitations. They may be current smokers, they may be social alcohol drinkers, they may be pregnant, they may have a BMI of greater than 30 but less than 40. They may have diabetes or hypertension or mild lung disease that's well controlled. So these are people those two classifications are most of the people that come into our offices. ASA 3 patients are ones that start to scare you a little bit. There are patients that have severe systemic diseases that are impairing their function. Those are patients with poorly controlled diabetes or hypertension. There are patients that have COPD. Those are patients that are morbidly obese with a BMI greater than 40. And to give you an idea what that means is a BMI greater than 40, someone who's 6 feet tall has to weigh 300 pounds to have a BMI of 40. Those are patients with active hepatitis, alcohol or drug abuse, implantable pacemakers, and multiple medical problems. ASA 4 patients will occasionally walk in your office. And when they do walk into your office, you actually hope that they walk out of your office. Those are patients that have severe systemic diseases that are constantly a threat of life. And you've seen these individuals in your office. Those are patients that walk in and they brought their own oxygen supply with them. Those are patients that have an implantable defibrillator in case they go into ventricular fibrillation. So these are patients that they have diseases that are constantly a threat of life. ASA 4 patients are unlikely to come into our office. Those are patients that have severe problems that are unlikely to survive any operation. And then ASA 6 patients are patients who essentially are brain dead. All right, in 2014, the American College of Cardiologists also came up with a risk stratification guidelines. And in combination with the American Heart Association, they tried to define risk on the basis of the surgery type. So you'll note that carotid, asymptomatic carotid surgery, eye surgery, breast surgery, those are actually relatively low risk procedures. On the other end of the spectrum, there major vascular surgery, those are things that are very, very high risk. So those of us in dentistry can be comforted by the fact that our procedures are relatively low risk. Another way we can assess our patient is actually talking to them. And this is a Duke Activity Status Index. It's called the METS. And METS stands for Metabolic Equivalence. And what you want to try and do is, based on what their activity level, trying to find how active they are. So one MET, so if you have someone who basically can just take care of themselves, eat, dress, and toilet themselves, basically walk around indoors, and walk probably no more than 1 or 2 blocks at ground level. That's one MET. Less than 4 METs is someone that does light housework around the house, such as dusting and washing dishes. So my wife would classify me as less than 4 METs because I don't do either one of those. Greater than or equal to 4 METs is being able to climb a flight of stairs or walk uphill, walk on ground level at 4 miles an hour, or run a short distance, do heavy housework like scrubbing floors, lifting or moving furniture. Again,
Dr. Maranon?
Yeah.
This is Ben, the president. I was just wondering, could you just talk a little bit louder or turn your volume up? Because some of our members are having difficulty hearing.
Hang on a second here.
Yeah, we can't hear you.
Can you hear me any better now?
Yeah, I think so. Try
Okay.
that.
All right,
Thank you.
I'll speak a little bit more slowly. Are there any questions because you couldn't hear me that you'd like me to address now?
I think we don't have any questions as of yet, so I'll keep you posted.
All right. So in terms of metabolic equivalence, like I said, doing heavy housework around the house, also participate in moderate recreational activities, golf, dancing, playing baseball or football, and then greater than 10 METs is participating in strenuous sports. So in terms of evaluating a patient, one of the things you want to look for is someone who actually is greater than or equal to 4 METs as kind of a floor in terms of what their activity level is. Okay. Now let's say you have someone that worries you, and you all understand that feeling. You have a patient that comes in, they have a long list of medications, they have a long surgical history, they just don't look right to you. That's an indication where you may want to consider consultation with their physicians. I just want to give you an idea of what my consultation form looks like. The first part of the form, obviously I address them. There's their name, date of birth. Here's the date, because you always want to do this to give them enough time to fill this form out. I mentioned that I want them to help me with my patient. I also mentioned that this letter is not intended for medical clearance purposes. I don't want them to feel like they're at risk for giving me information about that patient, but I'm just asking them to update me on their current medical condition. I tell them what she's coming in for. Mrs. Mouse will undergo the extraction of a mandibular molar tooth. Then I'm going to tell them about the nature of the procedure and any interventions that I might do. In this case, the surgery will be performed under intravenous sedation. Mrs. Mouse will be monitored with continuous capnography, pulse oximetry, EKG, and for blood pressure. I always like to highlight the fact that local anesthetic with epinephrine may be necessary. So local anesthesia with epinephrine is necessary for pain control and hemostasis. and then also comment that the local anesthesia will be used judiciously. Then I want to let them know that I understand this patient's medical history. Mrs. Mouse has a medical history significant for controlled hypertension that was diagnosed 10 years ago. She had a myocardial infarction in 2014, and she's status post coronary artery stent placement. Then I again ask, please provide me with an update on Mrs. Mouse's medical condition and any recommendations you may have as to her management. I let them know when the procedure is performed, and I ask them to return this form to me. I also ask them to provide me with any other consultations, EKGs, laboratory results that they think are relevant, and then I thank them for their participation. Now, I've established a checkbox system down here, which they fill out. The first one is the patient is in their best possible health and not at increased risk for surgery and anesthesia. So when going back to the ASA, that's like an ASA leading to maybe an ASA2. Okay. The second one is the patient is in their best possible health but has one or two medical problems, though well controlled, carry a slightly increased risk of surgery and anesthesia. So now we're clearly going into the ASA2. Next one is the patient is in her best possible health, but requires special management considerations during surgery and anesthesia. That's letting me know that this patient has some risk, maybe moving them from ASA2 to ASA3. And then ASA4 is the patient's health is compromised by one or more medical conditions that place this patient at increased risk for surgery and anesthesia. So that puts me closer to ASA4. And the last box I asked them to check is this patient requires medical evaluation prior to scheduling her procedure. What that means is they haven't seen this patient in a while, and before they can answer these questions, they want to see them again. On all of these top four, I asked for an explanation of why they gave me these top four indications. And then I ask if there is special management considerations, I'd like to see them and know what they are. That doesn't mean it's going to alter my treatment. I just want to know what their recommendations are. And then I ask to sign it and date it. And that's my medical consultation form. Okay. So I want to show you two good ones and one good one and one bad one based on the same patient. So this patient came to me. She's an elderly woman. She has a history of Parkinson's disease, and she has a deep brain stimulator that I want to know how to manage. But because of her advanced age, I want to also find out what medical problems this patient might have. So this is the first one that I sent to her neurologist, and I've clearly blanked out the names. But this is actually a well-written form for me, and it gives me a lot of information. So this patient said that she's in her best possible health but requires special management considerations during surgery and anesthesia. And then under the explanation, the doctor wrote, the patient's deep brain stimulator device will need to be turned off before surgery as electric cautery could damage the device or extension leads. The device can be turned off by the patient or by a relative. They also gave me the information of a contact at Medtronic who makes the deep brain stimulator, so I can ask some questions about this. So this is a well-written medical consultation form from a physician. So I want to give you next the letter from a gerontologist. And as a gerontologist, they should understand why their patients in general are at high risk. But this is the letter I got. And I just want to flash back to the other one. This is the quality of the facts. So this is a fax that I received. This is the quality of the facts that I received from the neurologist. And this is the quality of the facts that I received from the gerontologist. So first of all, you'll notice that there's no indications here. There is a signature that was done and the date that it was done. But the comment was last seen in March of 2018. And then under special management, I do not receive such requests from dentistry. I suggest that you do your own evaluation and determine if it's safe. So this patient, this individual doesn't really understand that I want to be a partner with them in terms of taking care of their patients. And clearly the wall between medicine and dentistry for this individual has not come down. All right, so after you've done your assessment, I've developed this table that kind of helps me decide how I'm going to take care of this patient. And A stands for this group, B stands and C stands and thereon. So A stands for antibiotics. Do I need to prescribe antibiotic prophylaxis for this patient? Does this patient have a condition where they may require antibiotics after my procedure? What sort of anesthesia will this person have? Can I use my standard local anesthetics, or do I need to reduce the dose? Is this someone who may need conscious sedation in my office, intravenous sedation, or general anesthesia? Along those lines, does this patient have an anxiety disorder related to dentistry that would require maybe some special management? Does this patient have allergies that might affect my treatments? For example, a latex allergy necessarily, or do I need to look at alternative pre-medication medications in the event that they have an allergy to penicillin or amoxicillin? Does this patient have bleeding problems? I'm sure you're all familiar with the thin 80-year-old woman who comes to your office and you look at her arms and there's bruises all over them. Is this patient taking medications that increases their risk of bleeding? Does this patient potentially have a bleeding disorder, a factor disorder, or von Willebrand's, or some other type of hemophilia? Does this patient have problems breathing? Do they have COPD? Do they have asthma? How is that going to affect the treatment that I do? Is this patient coming in with a tank of oxygen? How is that going to affect it? Chair. Is this patient in a wheelchair that can't be moved to your own chair? Is that patient who has a BMI of 40 come into your office going to sit in your dental chair? Is that chair going to be able to tolerate this patient? And what happens if you have to do CPR on this patient when they're in the chair? Are you able to do so in that case? Does this patient have comorbidities? Do they have diabetes? In addition, they have hypertension and coronary vascular disease. So does this patient have things that put them at increased risk? Does this patient have conditions that may alter treatment? Is this patient pregnant? What trimester of their pregnancy are they in? Under D, drugs. What drugs are these patients on? Do I need to be concerned about drug interactions with these patients? Devices, I touched on that just a moment ago. Does this patient have a defibrillator implanted? Does this patient have a pacemaker? How is that going to alter my treatment? How do I deal with these devices in the event of an emergency? Equipment. What equipment am I going to use? Am I going to use an electrosurgery unit that might compromise a pacemaker or a deep brain stimulator? What equipment am I going to need in the event that I can't move a patient into my regular chair? Am I going to need to bring in auxiliary oxygen to take care of this patient during treatment? And then, of course, once you've done this, you look at this entire list, you look at your consultations, and you look at your medical history and physical examination, and you start to think, if this patient has an emergency, first of all, what are the most likely emergencies that they might have? And am I going to be able to manage it? And in that regard, too, whenever I do a talk about medical emergencies, I always like to say the best way to manage a medical emergency is to prevent it. So think about preventative strategies that you might have for those patients during their time in your office. Okay, so this is the list that I was given by your board to talk about. Those are the things that they were interested in. Just to give you some insight, Dr. Yount and I spoke back in October last year, and I said, I kind of want to make this an interactive meeting where the audiences will ask me questions from the audience about medical conditions, and then I'll go ahead and answer those questions and deal with it. And then, of course, COVID happened, and so there wasn't going to be an in-person meeting, and that really disappointed me because I was actually looking forward to a trip to San Mateo. I was actually looking forward to speaking to you in person. But more than that, I was actually looking forward to seeing Carliza because she promised me a martini at the end of my talk. And clearly that's not going to happen. But again, this is the list. And what I'm going to do is I'm going to try and go through most of this in a rapid period of time. And I want to see if I can go ahead and get through it. If there are any questions about this list that I don't answer or that I can't get to, we can deal with that at the end. All right. The structure of the talk is actually going to be pretty much the same. Under each condition, I'm going to have a definition slide, an etiology slide, a diagnosis slide, incidence and prevalence, signs and symptoms, pathophysiology, medical management, mortality and morbidity, and dental management. I set this structure up because I'm someone that goes off on tangents, and the PowerPoint will get me back on tangents. I've actually also incorporated some tangents into this talk, and you'll see those later on. Okay, so let's start with diabetes. Diabetes, there's actually multiple types, but we're going to talk primarily about type 1, type 2, and gestational diabetes. Just so you know, other types of diabetes can be caused by exocrine pancreatic disorders, pancreatitis, pancreatic neoplasm, cystic fibrosis, hypothyroidism, Cushing's syndrome, and clearly all of those are beyond the timing of this talk. All right, so let's talk about type 1 diabetes. It's defined as, it's characterized by impaired or decreased secretion of insulin from the pancreas that results in hyperglycemia. Type 1 diabetes was previously described as juvenile or insulin-dependent diabetes, but we're also finding that type 1 diabetes can occur in any age, even though it is more common in young people. It only comprises about 5 to 10% of people with diabetes, and no one currently knows how to prevent type 1 diabetes. Etiology, no one really knows, okay? It is felt that there's an autoimmune phenomenon to this. It's also felt that there's a family history or genetic component to this. Patients with parent, brother, or sister that has type 1 diabetes is often more likely to have diabetes themselves. Monozygotic twins have a concordance of about 30 to 50%, and dizygotic twins have a concordance of 6 to 10%. So you can see the closer you are, the more likely you are to have diabetes transmission. And then, of course, there are environmental or infection possibilities. No one's really sure what the triggers are. Some feel that there may be a virus involved as a trigger, or there may be an environmental cause that stimulates the autoimmune response that results in the loss of beta cells. Okay, serologic markers. So if you have a family member that has diabetes, you can actually have a blood test done and a blood test from them. And these biologic marker or serologic markers can oftentimes let you know whether you're at risk for diabetes at some time in your life. All right, definition of type 2 diabetes. There's actually two components of diabetes. One is prediabetes, and that's a situation where the patient remains a normal glycemic, but they are starting to develop insulin resistance and increase in insulin production. Prediabetes oftentimes becomes type 2 diabetes, and that is a situation where patients become insulin resistant. Okay, etiology. Obviously, one of the likely causes of type 2 diabetes is prediabetes. The exact cause of type 2 diabetes is also unknown, but there's a strong family history. Actually, the family history for diabetes type 2 is much greater than diabetes type 1. Weight is also a significant cause. The more you weigh, the more likely you are to develop type 2 diabetes. Relative inactivity, the more inactive you are, the more likely that you are to have diabetes. Race and ethnicity is a factor. African Americans, Hispanic Americans, Native Americans, Asian Americans, and Pacific Islanders are at increased risk for developing type 2 diabetes. Okay, so how's it diagnosed? There's three tests for diagnosis of type 2 diabetes. One is a fasting plasma glucose, and that's where your doctor tells you, I don't want you to eat or drink anything for 8 hours, and we're going to come in and we're going to do a blood test for you. The second one is they give you some concentrated glucose solution. It's an oral glucose tolerance test. And then 2 hours later, they measure your glucose level in your blood. And the last one is A1C. A1C is actually tied to the binding of hemoglobin, glucose to hemoglobin, and it gives you an indication of your glucose control over the last 2 or 3 months. So here is a table that discusses what those findings need to be in order for you to be considered to be a type 2 diabetic. So if you have a fasting plasma glucose of greater than 126 milligrams per deciliter, you are actually considered to meet the criteria of diabetes. The 2-hour plasma glucose test, the fasting glucose test and this test are oftentimes done at the same time, where you do the fasting blood test first, you drink the Kool-Aid, and then you have the 2-hour test later on. So after 2 hours, if your plasma glucose is 200 milligrams per deciliter or more, then you're considered to be a diabetic as well. And your A1C, if your A1C is greater than 6.5, then you're considered to be in the diabetic class. Usually it requires one or more of these symptoms to make that diagnosis, or findings to make the diagnosis. The last one is if a patient comes in and they're showing signs or symptoms of hyperglycemia or a hyperglycemic crisis, and they actually take a random blood glucose and it comes in at greater than 200, that is also an indication that the patient has diabetes. Okay. Are there, with respect to diabetes, are there things that also go along with diabetes? And for an example, smoking. 21.6% of diabetics were also tobacco users. In terms of hypertension, 6.8% of patients with type 2 diabetes had hypertension. And with respect to high cholesterol, 11.2% of diabetics had high cholesterol. So there are associated comorbidities and complications associated with type 2 diabetes. All right. With respect to gestational diabetes, it's also insulin resistance, but it occurs during pregnancy. And the etiology of this has to do with placental hormones. So the placenta actually, in certain groups of people, in about 5 to 9% of pregnancies, certain groups of women, will produce these placental hormones that result in insulin resistance. Insulin resistance is more common the older you are. Typically, there's a family or personal history of gestational diabetes. These women will oftentimes also have large, high-weight babies. Again, patients that are overweight during their pregnancy, inactivity, and the same racial classifications are at higher risk for developing gestational diabetes. All right, so in terms of the insulin prevalence, pre-diabetes, 88 million people ages 18 years or older have prediabetes. 65, or in the age group of 65 or older, 24.2 million people have prediabetes. With respect to diabetes type 2, there are 34.2 million diabetics currently, or in 2018. 26.9 of them were diagnosed. And what that means is they came in and they already had a diagnosis of diabetes when they had their blood tests done. There were 7.3 million undiagnosed, and that sounds kind of funny to say. How do you know what they are if they're undiagnosed? These are people who said they did not have diabetes at the time of their blood test, and after the blood test, it was determined that they did have diabetes. So that's where the 34.2 million comes from. In 2018, there were 1.5 million new cases of diabetes in patients 18 years or older. It was greater in patients that were 45 years of age or older. In patients that were non-Hispanic Blacks, the ratio was 8.2 per 1,000 persons. Those of Hispanic origin were 9.7 per 1,000, and non-Hispanic whites were 5 per 1,000. All right, so we're going to talk about what it feels like when you have when you are experiencing the spectrum of diabetes. So if someone is hyperglycemic, their skin will feel hot and or be dry. They're going to have increased thirst. They're going to have more frequent urination. They're going to be tired. They may have nausea and vomiting. They may exhibit shortness of breath. They may have stomach pains. If you smell their breath, it will have a fruity odor to it, and their mouth will be exceedingly dry. On the opposite, hypoglycemia, patients are going to feel shaky or nervous. They may be anxious. They may have fatigue. They may be weak. They may be sweating. They may be hungry. So when I think about hypoglycemia, I think about Thanksgiving. And I think about the fact that I'm really waiting for Thanksgiving dinner, and so I haven't eaten anything all day. And I'm just smelling the dinner being prepared, and I'm having some of these same symptoms. So you'll feel hunger. There may be nausea, dizziness, or lightheadedness. Patients may have difficulty speaking, and they may be confused. So in terms of the pathophysiology, we have to think about what insulin does. Basically, what insulin does is it takes glucose out of the circulation and puts it in a storage form. And what it also does is it stops the opposite. It stops glucose from being utilized. So this is how it works. You take in carbohydrates into your gut. They are in the form of glucose, fructose, and galactose. That all goes into the systemic circulation. In the liver, glucose is converted into glycogen stores. And glucose, fructose, and galactose are converted into glucose, and they actually go into triglyceride stores. In addition, glucose may go into forming energy, and we all remember the Krebs cycle in the production of ATP. And then the byproduct of that is the formation of CO2 and water. On the other side, in terms of how glucose is utilized once it's been stored, triglycerides are broken down into glycerol, amino acids, and lactate, and it undergoes gluconeogenesis, which produces glucose that goes into the systemic circulation. And the glycogen stores undergo glycogenolysis, and glucose is formed and goes back into the systemic circulation. This is a pancreatic islet. There are blood vessels. These are all the beta cells. These are the exocrine glands outside, and there's various other glands that are involved in digestion. All right, so the pathophysiology of type 1 diabetes. I talked a little bit about autoantibodies, patients that have serologic markers that may indicate that they are at risk for developing diabetes. And again, I also mentioned there's a trigger, whether it's environmental, viral, or infections that causes a trigger for these autoantibodies to kick in. And there is an autoimmune response that results in beta cell destruction. And then because insulin is not being produced or there's a decreased production, it results in hyperglycemia. Ben, I just want to stop for just a moment, and I just want to make sure you had no more problems with audience members being able to hear me speak.
No, I think we're good now.
Okay. All right. Thank you.
Thank you.
In terms of the pathophysiology of type 2 diabetes, I already discussed the relationships with the relationship of prediabetes, where people may be normal glycemic, but then shortly after that develops, some patients will develop insulin resistance, where the cells no longer accept insulin to remove glycogen from the systemic circulation. This causes the beta cells to increase insulin production, and it creates a vicious cycle where you have insulin resistance resulting in increased insulin production, and eventually the beta cells just give out, and that results in hyperglycemia. Okay, how are these patients managed medically? In type 1 diabetes, the first step is lifestyle changes. They're given dietary instructions. These patients tend to be thin, but activity is asked to be increased. They'll be started on insulin and given instructions in terms of how insulin should be used. There are different monitoring devices that they may be given. One would be a continuous glucose monitor. There are insulin pumps that work in conjunction with continuous glucose monitors, and there are other insulin delivery devices that can be used. A lot of research is being done, and there are examples of pancreas and islet cell transplants. These may be more likely in the future, as is adult stem cell therapy, where stem cells are actually converted into beta cells. But you have to remember that type 1 diabetes is an autoimmune phenomenon. So for a pancreatic or islet cell transplant, those individuals are going to need to be on anti-rejection medications for the rest of their life. And the same would hold true for patients who eventually are on adult stem cell therapy. So that's one of the hurdles to the more frequent use of those modalities. Okay, these are the different insulins. They are used depending on the patient's medical condition and their control. So you have short-acting insulins, you have rapid-acting insulins, you have intermediate-acting insulins, there's long-acting insulins, and there are combination insulins that combine both short-term and long-term insulin therapy. So in terms of monitoring, I talked about a glucose monitor, and a glucose monitor is this one on your left, and basically a transmitter is placed that goes through the skin, and either on a minute-to-minute or every 5 minutes, the individual is given an idea of what their blood glucose level is. Okay, and they can then give themselves insulin depending on what those values are. An insulin pump is a little bit different. An insulin pump is a pump that actually stores insulin, and there's a battery, and you can actually deliver insulin through this pump depending on what your blood glucose level is. And then there are combination devices that have both a glucose sensor and an insulin pump. And in this case, what happens is the glucose sensor has a transmitter that sends the blood glucose level to the insulin pump, and the insulin pump delivers the insulin appropriately. And there are algorithms that have been developed for each one of these to determine, based on the individual patient, what the insulin requirement will be. Okay. Also with type 2 diabetes, lifestyle changes, and more importantly, in type 2 diabetes, there are lifestyle changes, because lifestyle has a significance in the etiology of this disease. So patients will be given dietary instructions and recommendations. They'll be given instructions in terms of improving or increasing their level of activity. They will be given weight reduction protocols to follow. And it's important to note under family, I talked about the concordance in family members with diabetes. You have to remember that diabetes does run in families, but families also have the same habits often. And so those lifestyle changes may involve the family as well in terms of making those changes. Patients, if diet and exercise do not change the diabetic profile, patients may be started on oral hypoglycemic agents. And if that's not successful, they actually may need supplemental oxygen. So these are examples of oral hypoglycemic agents. These are bioguanides, and the most common one here is metformin. There are also alpha-glucoside inhibitors that can be given, but you can see the wide variety of medications in terms of just this particular class of medications that can be given to diabetics. All right, so let's talk about mortality and morbidity. I gave you kind of examples of what happens when someone has hyperglycemia. Well, there are two medical emergencies that can occur during a hyperglycemic crisis, and that's where glucose levels, blood glucose levels, become very, very high. There are ketoacidosis and hyperosmolar hyperglycemic non-ketotic syndrome, HSNC. And those are, in fact, medical emergencies. And I'll talk to you about the characteristics of those in a moment. Hypoglycemia is common in patients that are on insulin therapy. And there's a condition called insulin blindness, where someone who is on insulin therapy for a long time may not be able to appreciate that they're hypoglycemic. But I talked to you about what it feels like to have hypoglycemia. In terms of the longer term complications of diabetes and the mortality and morbidity associated with it, cardiovascular disease is in there, nerve damage or neuropathy, kidney damage, eye damage, which is retinopathy, and other skin diseases and infections. Okay, so ketoacidosis. Ketoacidosis is, like I said, a medical emergency. I was trying to do a video for you, but wasn't able to do it, so I'm actually going to describe the video. One of the characteristics of ketoacidosis is something called Kussmaul breathing, and it is a rhythmic breathing and with deep breaths. And the video that I was going to show was actually a 10-year-old boy that presented to their pediatrician with altered mental status, and was having these breathing symptoms, and the patient had no previous history of diabetes. So what Kussmaul breathing sounds like and looks like, and I'm going to try and do some acting for you here, is so it's rhythmic, deep breathing, and it is a frequent sign of ketoacidosis. So I talked about this 10-year-old that presented to their pediatrician's office with Kussmaul breathing. That may also have been a patient that comes to your office with a severe toothache and infection, and the infection becomes overwhelming, and the patient's blood glucose increases, and that patient goes into ketoacidosis. So it is something that you should be familiar with and recognize, because that patient could walk into your office. Okay. In terms of gestational diabetes, the concerns are excessive growth of the baby. Patients will oftentimes be born with a weight of 10 pounds or more. Preeclampsia is a pregnancy complication that results in severe hypertension. Babies that are born to patients who have had gestational diabetes will sometimes develop low blood sugar shortly after birth because the blood sugar was so high in utero. There's also the possibility of increased risk in diabetic and type 2 diabetes for both the baby and the mother later in life. And then, of course, there's the possibility of death associated with gestational diabetes. All right, so what's the dental management? Okay, first of all, you want to say, what does this patient have if they have if they have diabetes? If they don't admit to diabetes, you should take a look at certain characteristics that they may have. Are they overweight? Do they have headache? Do they have dry mouth? Do they have repeated skin infections? Have they complained about blurred vision? Paresthesias, especially affecting the extremities. Progressive periodontal disease might be something that you notice, or multiple periodontal abscesses. So those may be indications that this may be an undiagnosed diabetic, and you may want to consider referral. You should also have, a fingerstick blood glucose monitor. So if you consider someone who may have diabetes, it may be appropriate for you to do a fingerstick blood glucose to determine if their blood glucose levels are high. If they have diabetes, you want to find out what type they have and what's their level of control. What's their A1C? How often do they see their physician? Those are things that you would want to ask. And if they're on insulin, you want to ask them what type of insulin are they on? How good is their control? How often do they check their fingersticks, the fingersticks, and how often do they see their physician? Okay. As I mentioned before, diabetics will oftentimes have accelerated periodontal disease. There may be gingival hypertrophy. There may be xerostomia from the polyuria and dehydration. These patients will oftentimes have delayed wound healing and will not respond to infections as fast as your other patients. You may notice that these patients have candidiasis or other yeast infections because they're immune compromised. And again, there may be burning or pain of the periodontal tissues that may be associated with neuropathies. Okay. You also need to figure out, how am I going to deal with their insulin dose regimens? If you're doing a procedure that is non-invasive and patients can resume their normal diet relatively quickly, you may not need to alter their insulin dose. If there are patients where you expect that they may not have the same oral intake that they had before surgery for a considerable period of time, this may mean that you should have consultation with their endocrinologist or internist who's managing their diabetes to determine whether there may be dose changes related to their insulin. In my office, whenever I treat a diabetic, I do a fingerstick blood glucose level when they arrive at the office, and I do a fingerstick blood glucose level when they leave the office. Epinephrine is actually acts as the opposite of insulin, and it can increase blood glucose levels. So you have to be concerned and careful with your epinephrine dose and intravascular injection. Empiric antibiotic therapy. If this patient has an infection, am I going to go ahead and prescribe them antibiotics, and for how long? Do I take cultures of those and ask for sensitivities in the event that this is an infection that may have resistant organisms? And then you also want to get an idea of what the appropriate antibiotic would be for this patient. After surgical procedures, these patients need to have scrupulous wound care and oral hygiene because there are considerable risk for secondary wound infections. And again, you always need to consider emergency management. Is this a patient that may have a hyperglycemic episode? What do I do if this patient has hypoglycemia? And to go back to emergency management, there's not much that you're going to be able to do in your office for someone that is having a hyperglycemic episode, such as HNS and ketoacidosis. Those are emergencies that need to be managed in the hospital. So you need to think about calling 911, or you need to call 911 in those situations. Patients that are hypoglycemic, you need to have packs of sugar. You need to have cake frosting. You can have other glucose substitutes that have available in the event someone has a hypoglycemic episode. But that definitely needs to be preceded by a fingerstick blood glucose level to make the diagnosis of hypoglycemia. All right, we're going to go on to the next group, and this was on the list, and it's autism. And autism, the word autism actually comes from the Greek autos, which means self, and ismos, which means a state of being self-absorbed. It's important to note that autism is a disorder. It's not a disease. There are many brain disorders that fall into the autism category, 5 specifically. Autistic disorder, pervasive developmental disorder, not otherwise specified, and that goes to the ICD-10s and DSM-5s, Asperger's syndrome, childhood degenerative disorder, and Rett syndrome, which is a rare genetic disorder. Okay, etiology. Genetics plays an important role in this. There are families that have multiple children with autism. Children born into autistic families have an 18% risk of having autism as compared to children born to families without autism. There are indications that infections such as viruses may also be involved. Toxic exposure. There are studies that from North Carolina, Pennsylvania, and California that show that patients that are exposed to smog have higher incidence of autism. Parental age. The older the parents are, both parents, incidentally, the higher risk of autism. Excuse me a second. Coexisting medical conditions, primarily seizures, Down syndrome. All of these may be associated with autism. I'm sorry, not Down syndrome. Fragile X syndrome, tuberous sclerosis, and other immune system problems. My apologies. There are also enteric nervous system and central nervous system disorders, and there's something called the GI brain association, where some of the same mediators that mediate and neurotransmitters that mediate neurotransmission in the gut are also mediators in the brain. And patients who have other intestinal problems, constipation, diarrhea, those are patients that oftentimes will have autism. Then there are also other conditions. Developmental delays, obstetric complications, and phenylketonuria are all increase the risk of developing autism. Okay, so autism is actually not defined by any blood test. It's actually defined by evaluation of behavior. So if someone has persistent deficits in social communication or interaction, they don't talk when they should be talking. Patients that have repetitive patterns of behavior, interests, or activities. Patients who present in the early developmental period with some of these symptoms. Impaired social, occupational, or other areas that interfere with current functioning. So patients that don't interact with other kids are important. And then it's important that these disturbances are not associated with other global delay conditions. Okay, the incidence globally, there are 2.4 million people with diabetes in 2015. The incidence is increasing. In the 1960s up until the 2000s, the incidence rate was approximately 1 or 2 per 1,000 people worldwide. In March of 2020, in the United States, the Centers for Disease Control announced that 1 in every 54 children has been diagnosed with an autism spectrum disorder. Patients that are infants to the age of 2, signs might be will not make eye contact, will not respond to a parent's voice, will not babble or do baby talk at some point around 1 year of age, will not respond to their name, will not smile or laugh in response to others' behavior. Now, at about the age of 203, this is the list of potential disorders. Again, some of the same ones that you saw before. There may be delays in language comprehension, difficulty speaking, monotone speech. There may be social withdrawal, repetitive movements, self-abuse behaviors. These are common findings in patients who are on the autism spectrum at the age of 2 or 3. Again, the pathophysiology, I talked a little bit about genetics, but there's also the possibility of de novo mutations where something happens, whether it's a virus or an infection that causes a mutation in the DNA. I talked to you about a little bit about neural anomalies, where I did not mention neural anomalies. These are patients that have increased synapses in the brain. There are also studies that show that the brain actually increases in size postpartum in patients on the autism spectrum. Oftentimes these patients are premature. There's decreased levels of gamma-aminobutyric acid, which is a neurotransmitter, and glutathione and N-acetyl aspartate, and those are antioxidants in the brain. These patients will have elevated serotonin. I talked about the gut-brain association and those neurotransmitters. There's a theory that these may be secondary to inflammation, and that the same thing that's responsible for the immune response is responsible for the gut and brain, or the gut problems and autism spectrum disorder. Again, I mentioned patients that are born prematurely, and then going back, environmental. Are there things in the environment that are causing an increase in the number of autistic patients? In terms of medical management is primarily behavioral. These patients are given speech therapy. There may be sensory integration therapy, and where these patients may be sensitive to light or sounds. And so there are desensitizing therapies that take place. These patients may be sensitive to touch. They may be sensitive to smell. The smell of disinfectants may affect these children. In terms of medical agents that are used, agents like Concerta will be used to treat hyperactivity. Prozac is oftentimes used to treat obsessive compulsive disorders. These patients may be on anti-seizure medications. And one drug that is currently been approved for patients with disabling, repetitive, and self-injuring behaviors is naltrexone, which has been used for patients with alcohol and opioid addiction. Okay. For those of you who feel that you don't have the training necessarily to take care of autistic patients, the Autism Treatment Network actually created a toolkit for dental professionals. The website is here, and you can email me if you want me to send you this website. But basically, it's a cookbook. It starts out with how you treat patients with autism spectrum disorder in terms of how you manage them as they move through the office. Okay, so you have to think about your appointment. Okay, so there's a number of things that you need to do, some treatment strategies that you need to have. With respect to the appointment, it may be helpful to have a pre-appointment with just the parents, where you go ahead and discuss what can the child do, what can the child not do, what are the potential triggers and sensitivities this patient may have. Those are things that can be addressed at the pre-appointment. It may even be helpful for you to start to do some training with the patient even before they come to the office. Pictures of the office that parents can share to familiarize the patient with the office are important. So those are things that you can do during that pre-appointment. Now, with respect to the appointment with the patient, this is really important. Everyone who comes in contact with that patient needs to be sensitive to the potential condition that this patient has and how they interact with the environment. So the lights may need to be turned down. They may need to be put in a room that doesn't have a lot of stimulation. Repetitive music at low levels may be helpful. So those are important. With respect to behavior, you can do successive approximations where a little bit like conditional therapy or conditional programming, where you bring a child in and you have them sit in the chair. You start to introduce hand instruments to them. In terms of your procedure, you may need to start with easy procedures first, and then advance to more advanced procedures. You may consider on those advanced procedures putting time limits and telling the child, this is what you're going to feel, and we're going to do it for 5 seconds. We're going to do it for 10 seconds, so that they have an idea of what's going to go on. In communication, it's very important to try and establish communications with patients. Sentences need to be short and they need to be clear. You may use communication to elicit movements. Say, hands on your tummy, sit straight, look at me. Again, these are communication techniques that can be used, but it's also based on what the patient is able to do. Sensory are already mentioned. Dim lights, low repetitive music or no music at all. And patients that are involved with, or staff that's involved with autistic patients, should keep their movements to a minimum so that they don't distract patients. And then other distracting elements within the operatory should be removed. It may be important for these patients to have to use a closed operatory that has been established for them. It's also very important that a pattern needs to be developed. So appointments always at the same time, appointments always on the same day, same staff members participating during the appointment, using the same room during the appointment. And it's oftentimes helpful to have parents available in the operatory, but that's based on the individual situations. With respect to how you deal with patients who have behavior problems that might interfere with treatment, deep touch is important, is better than a light tap. Autistic spectrum disorder patients respond more to deep touch. And then there's the question about protective stabilization, which is a use of euphemism for restraints. There's debate with respect to the use of restraints. Some feel that that restraints can oftentimes have a comforting effect in children. They're wrapped, they can feel themselves, and that has a comforting effect. Other people object to the nature of restraints and what it means in managing patients. If restraints are going to be used, it's very important that parents provide appropriate consent and understand the alternatives for using restraints, and also the risks associated with not using restraints. With respect to how to manage patients, are these patients high functioning enough that they can be treated with local anesthesia alone? Will these patients require conscious sedation or nitrous oxide and oxygen? Or are they patients that will require intravenous sedation or general anesthesia? If more advanced anesthetic techniques, even including conscious sedation, it may be appropriate to have consultation with their primary care physician so that they can weigh in on the management of these patients. Okay, so in terms of dental management, one of the things that you notice about most of the medications that are given to autistic patients, they'll cause xerostomia. They may cause difficulty swallowing, difficulty in taste. There may be sores in the mouth. These patients may have gingivitis. They may have swelling of their tongue. And so all of these things are important to know with respect to the medications that they may be taking for this disorder. Okay. Kind of gone through the first two. Wanted to see if there were any questions out there that people would want to hear about.
We do not have any questions yet, but if anybody would like to ask Dr. Maranon something, please put it in the question and answer box, and I will be more than happy to have him answer it for us. Thank you.
Yeah, no problem. And like I said, I kind of want this to be as interactive as possible. If some of you are dozing off, please make sure you let Dr. Yount know that, so I might be able to do something that spices this thing up a little bit. But I definitely want this to be as interactive as possible. Okay, oops, we're going to next to hypertension. Okay, normal blood pressures now are defined as a blood pressure less than 120 over 80. Patients that are considered having pre-hypertension now are patients who have a systolic blood pressure of 120 to 129 and a diastolic blood pressure of less than 80. Patients that are in stage 1 hypertension have a blood pressure that's 130 to 139 over 80 to 89. And patients that are in stage 2 hypertension are patients that have a blood pressure of 140 over 90. So there are two types of diabetes, essential, it's also called primary and idiopathic, and then secondary hypertension. And in essential hypertension, there is no identifiable cause for why this patient has hypertension. It's also the most common cause of hypertension.
Dr. Maranon, we have a question in regards to the last topic.
Yes.
One of our attendees asked that we're seeing more autistic patients. Do you think there's a higher prevalence of autism? And if so, why?
Yeah, you know what? That's really unknown, but you're exactly right. I think if you go back to what I was talking about, in the 1960s, the prevalence of autism was 1 or 2 per thousand worldwide. And this year, the CDC came out with a ratio of 1 to 54. Now, like I said, no one really knows, but some people may think about that Nature article that described the possibility of vaccinations being involved with autism. That article has been withdrawn, and multiple studies have shown that that's not a consideration. Also, there was initial feeling that parents' interaction with their children might be responsible for, or their parents' behaviors might be responsible for the development of autism in children. That has also been refuted. So again, there's multiple reasons why, and a lot of research is being done, but no one really knows why the incidence of autism is increasing, but it is increasing at an alarming rate. Did that answer that question?
Yes, it did. Thank you very much. And what about the age of parents when they have their children? Is that a factor?
It is. So I think I mentioned the age of both parents is, so not just the mother, it's also the father, are increased risk factors for the development of autism spectrum disorder. And so you're talking right now, we're seeing parents that, well, to give you an example, my daughter-in-law was 38 when she gave birth to my grandson, and she was 40 when she gave birth to my granddaughter. So you are seeing patients that or parents that are having children later in life, and that's been going on for some time. Thankfully, both of my grandchildren are healthy, but age certainly does have a factor and is a risk factor for developing autism spectrum disorder in children.
All right, thank you very much.
Okay. All right, so back to hypertension. Okay, so this actually talks about the incidence and prevalence of hypertension in patients that are over 18, and this is based on sex. Okay, so you'll see that as you get older, for both men and women, the incidence of hypertension increases. And in fact, the incidence of hypertension increases faster in women as women get to be the age of over 60. This is an age-adjusted prevalence of hypertension among adults. And this has to do with their race. So you'll notice that non-Hispanic Blacks have a higher incidence of hypertension for both men and women. And for non-Hispanic whites, non-Hispanic Asians, and Hispanics, the levels are fairly close together. So non-Hispanic Black individuals have a higher risk of developing hypertension. Okay, so signs and symptoms. In kind of pre-hypertension, patients will have elevated blood pressure. So just to give you an example, when I'm in the office and I'm having a stressful day, I'll measure my blood pressure and it'll be 140 over 85, 140 over 90, and on pay days it's a little bit higher. And then I'll go home and do a little bit of reading and watch a little television, and my blood pressure will drop to 150 over 80. 115 over 80, I'm sorry, 115 over 80. So blood pressure readings need to be taken at different times, but consistent elevations in blood pressure, especially into that low dose range or low range of 120 over 129 to 80, those are indications that there may be pre-diabetic, pre-hypertension. Patients who also have headaches, dizziness, sometimes ringing of the ears, and on eye exam, and I'll show you examples of that in a moment, there's narrowing or sclerosis of the retinal arteries. So when your doctor looks in your eyes, this is kind of one of the things they're looking for, early signs of hypertension. Okay. In advanced hypertension, there may be rupture or hemorrhage of the retinal arterioles. There's a condition called papilledema where the optic disc swells. Patients may develop left ventricular hypertrophy that would be diagnosed on an echocardiogram. It may be noted on urinalysis that they have protein in their urine. They may start to develop congestive heart failure. They may develop chest pain. There may be associated renal failure. As patients get older, there's a higher incidence of dementia and encephalopathies. So here's a normal optic disc and a normal retina. You'll see the arterial arteries are well formed. They're consistently thick. And then you have a very localized optic disc. In sclerosis of the arteries, you'll notice that these arteries are now very thin. Matter of fact, they're so thin, they're actually almost at the level of the retinal veins. So this is an example of atherosclerosis affecting the retinal arteries. And then this is an example of papilledema. You found that you previously saw that well-formed and shaped optic disc. Now you look how it is swollen. And then you also look at the retinal arteries, also how swollen those are. And this is actually caused by an increase in intracranial pressure, which is also a side effect of hypertension. Okay, so what is the pathophysiology? We don't really know what causes it, but really what essential hypertension is failure of regulation of the vascular system in the body, okay? And there are multiple factors that are involved with that. There are neurohumoral mediators that affect vascular reactivity, whether the vasculature dilates and relaxes or contracts. There are mediators that affect the circulating blood volume, and there are mediators that also manage blood viscosity. Cortisol and stress will have an effect on hypertension. Cardiac output. So patients that have a higher sympathetic tone and higher cardiac output may have signs of hypertension. So this is more associated with the young, but then also in patients who have sodium retention, they may have this type of high cardiac output hypertension. I mentioned, of course, loss of blood vessel elasticity, and then also arterial stiffness that become problems with it. There's also a genetic predisposition. I mentioned salt a moment ago, excess salt intake, and there may be an increase in adrenergic tone. So again, I mentioned sympathetic tone being a possible mediator.
Just to specify, Dr. Maranon, what are non-Hispanic Asians?
Well, there are Asians that actually live in Hispanic countries. And so I think they've made that was part of the survey. But that's, that's a really good question.
Okay, thank you.
Right. Okay. Right, in terms of how blood pressure is regulated, as you remember, blood pressure is primarily regulated by the kidney. So if the kidney notices a drop in blood pressure or a drop in blood volume, it releases renin from the kidney. Now, angiotensinogen is released from the liver, and renin actually converts angiotensinogen into angiotensin 1. Then angiotensin converting enzyme, the ACE enzyme, which is released from the lungs, actually converts angiotensin 1 to angiotensin 2. Angiotensin 2 acts on the adrenal glands that stimulate absorption, the reabsorption of salt and water in cases where patients are dehydrated. And then angiotensin 2 actually controls and stimulates the vasculature to constrict them to increase blood pressure. So that's the renin-angiotensin system, as you recall. Okay. Pathophysiology, again, I mentioned cardiac output and circulatory volume, vessel caliber, elasticity, and reactivity, mediators that actually control that stuff. Neural stimulation and renal artery stenosis are causes. Chronic renal disease, patients that have advanced kidney disease will have hypertension. Primary aldosteronism and the excess secretion of aldosterone is a concern. I mentioned stress and me and my blood pressure during the day. Obstructive sleep apnea. So we may be providers that help to recognize sleep apnea.
Dr. Maranon, we have another question. Is the blood pressure regulated after being high? Will the eye vessels revert to normal?
Well, to use my example, it depends. If you have hypertension that goes on for a long time, so you have chronic hypertension, vessels will lose their elasticity and arteries will remain stiff. So you may have chronically high blood pressure in multiple situations. But to use my example, my blood pressure is somewhat higher when I'm under stress and I'm working, but it drops down to normal when I have an opportunity to relax. So it depends on what state of hypertension you're in, whether you're whether you're normal, whether you have pre-hypertension, or whether you're in stage 1 or stage 2. Does that answer?
Yeah, it does. Or if it's payday.
Or if it's payday, exactly. Right.
Thank you.
All right. So I mentioned sleep apnea. Sleep apnea, we can help diagnose. One of the things you look for is you do a Mallampati exam and to see how much of the soft palate and uvula can you see. You look at tonsils especially, and this is actually especially important in kids because there may be an association between sleep apnea and ADD and ADHD. Because you can imagine if a child is not able to get a good night's rest, it may affect their ability to pay attention during the day. But in addition to your oral pharyngeal examination, you want to look at the size of the tongue. So you want to look at the size of the tonsils. You want to look at the whether you have retrognathia or not. You want to look at the circumference of the neck. So if you have someone who has a neck circumference of greater than 17 inches, that patient is at risk for for sleep apnea. There's also the Epworth scale. It's a test that you give to determine whether it's a written test. It talks about, do you fall asleep during conversations? Have you ever fallen asleep while you're driving? So there are a number of tests, questions on that test. And depending on the number of positive responses, it may be diagnostic of sleep apnea. So those are things that you can do in your office and make the appropriate referral to either a sleep physician or a pulmonologist to help with the diagnosis of sleep apnea. Patients that have hyper or hypothyroidism have a higher incidence of hypertension. Mentioned pheochromocytoma, and then preeclampsia is the hypertension associated with gestational diabetes. And coarctation of the aorta is actually narrowing of the aorta as it leaves the heart. And so that is also associated with hypotension. Okay. So how are these managed? How is hypertension managed medically? The first things, again, are lifestyle changes. Get the person to lose weight. Get the person to be more active. Tell them to watch their diet, especially sodium intake. Those are things that are primary mediators of hypertension, especially early hypertension. And interestingly enough, as with type 2 diabetes and hypertension, just lifestyle changes alone can sometimes convert a patient into someone who is a type 2 diabetic or someone who's stage 1 hypertension into someone who's more into the normal range. In terms of medications that patients are given thiazide diuretics as the primary mode of treatment. I remember when I was early in practice, patients were primarily given Lasix as a first-line drug to reduce blood volume, and a beta blocker to reduce blood pressure. Now the treatment goes to thiazide diuretics, calcium channel blockers. Talked a little bit about angiotensin converting enzyme, and then inhibitors to angiotensin 2 receptors on the adrenal gland. Those are ARBs. So those are frontline treatment for patients with hypertension now. Mortality and morbidity. The longer you have diabetes, the more likely you are to have heart disease, whether it's congestive heart failure, whether it's arrhythmias, whether it's a coronary artery stenosis or cardiovascular disease. All those are associated with increased and long-term hypertension. Strokes are also increased in patients that have prolonged hypertension. And of course, the sequela of all of this is an increase in likelihood of death, okay? So how do we treat these patients in the office? So the first thing we do, and in my office, one of the things that we do is do vital signs of consultation. I want to know when this patient walked into my office, what their blood pressure was, so that I know that if they come into treatment and their blood pressure is higher than that, I know that this actually may be an anxiety or stress component that's raising the blood pressure. If I come in and I see a patient whose blood pressure is high, first of all, I'm going to consider whether this patient needs appropriate referral. That's going to be based on history. I'm going to ask them, do you see your physician? Have you ever been told you had high blood pressure? Have you checked your blood pressure at home or at the CVS? And have you ever shown signs of high blood pressure? And depending on that, the appropriate referral might be done. You may have a patient who comes in and you notice their blood pressure is high. Let's say they come in and they have a blood pressure of 180 systolic over 110 diastolic. That may be a patient that you choose not to treat in your office, and you make the referral to a physician. For the most part, if that patient walked into the office, I would suggest deferring treatment, but that's not a patient that you need to refer to the emergency room for treatment. That person is not symptomatic, and so you need to contact their primary care physician and make sure that patient schedules an appointment for evaluation of their blood pressure. And that treatment, unless it's emergent, should not be performed until the blood pressure is under control. Patients that are on medication for blood pressure, one of the things that you need to be concerned about is chair movements. So depending on what medication they're on, they may not respond appropriately to changes in chair position. For example, someone who's on a beta blocker or a calcium channel blocker may not be able to increase their heart rate to compensate for the change in position. So they actually may faint on you if you hit the eject button on your dental chair at the end of your procedure. So slow chair movements may be appropriate for patients with a history of orthostatic hypotension. You may also want to consider, do you need to modify the amount of epinephrine that you give these patients? Typically, these patients should not receive, depending on their hypertension and how bad it is, should not receive more than 4 carpules of 2% lidocaine with 1 to 100,000 epinephrine, which essentially comes out to 0.4 milligrams of epinephrine. If you think about it, that's 0.1 milligrams of epinephrine is in each carpule of epinephrine. That's where the 1 to 100,000 comes from. And so you may need to consider, do I need to limit the amount of epinephrine that I inject in this individual? Do I need to dilute or use a more dilute form of local anesthetic? If I'm doing multiple procedures at a longer period of time, do I need to stage my injections? So I inject the first site first, perform my procedure, and as I'm getting ready to perform the next site, consider giving local anesthetic to that site as opposed to giving local anesthetic all the time. Everywhere at the same time. And then clearly concern over intravascular injection is going to be important. With respect to dental management, if you look at someone who has a history of hypertension, you need to consider, is this a patient who also has diabetes? Is this a patient that also has heart disease? Are these things that I need to maybe consider and modify my treatment? Okay. Other dental effects of antihypertensive medications may be xerostomia, especially with the diuretics, and actually most of the medications will cause the mouth to get dry. Gingival hyperplasia is common with some medications, loss of taste. There may be lichenoid drug reactions, so there may be conditions that appear somewhat similar to lichen planus that appear in the mouth. These typically are unilateral, whereas opposed to lichen planus oftentimes being generalized, and they tend not to have the erosive look of lichen planus. Cough is oftentimes a side effect of the calcium channel blockers. And then I mentioned the ACE inhibitors and the ARBs. There's a condition, if you watch the commercials about ACE inhibitors and ARBs, there's always a disclaimer that says this may cause swelling of the tongue. It's not uncommon for those medications to cause angioedema. Angioedema is also, the angioedema from ARBs and ACE inhibitors is refractory to epinephrine. So it's not like you would treat this as an anaphylactic reaction or a normal angioedema reaction. So that angioedema can be a life-threatening emergency if not recognized and treated appropriately. So knowing what knowing the medications that your patients are on is really important. Okay, so let's talk about stroke. Before I leave hypertension though, are there any questions about hypertension? Any more questions about hypertension?
Yeah, I don't think so.
Okay.
We'll just keep on going. Thank you.
All right. Those of you that are still awake, can you raise your hands? Ben, did we get any hands raised?
24 hands up. They're all awake.
Okay, Nakia, can you call those other 6 people? Okay. All right. So let's talk about stroke. As you know, there's 2 types of stroke, and I'm going to go through this in the same manner. There's embolic and hemorrhagic strokes, right? Let me actually do a little bit more on the slide. They're more likely to develop after the age of 55. If you have that, your chances of having a stroke increase or actually double every 2 years. Blacks, Hispanics, American Indians, Alaska Natives are at higher risk for developing a stroke than non-Hispanic whites, and in this case, just Asians. Okay. Patients who've suffered a stroke or had a TIA in the last 6 months should be considered unstable. If you're going to treat these patients, clearly consultation with their physician is highly recommended. For patients that have an embolic stroke, they may be on anticoagulant therapy, so there may be an increased risk of bleeding. You may need to determine what their international normalized ratio is, their INR, if they're on Coumadin. You also have to remember that some of the medications that you might prescribe, whether it's Flagyl or tetracyclines, can interfere with drugs like warfarin. And then you also, as I mentioned before, with hypertension may need to adjust your local anesthetic dose. In terms of the oral manifestations of stroke, there may be unilateral paralysis of the face, as you know. That may include a flaccid tongue, difficulty swallowing. These patients may have impaired motor function, so in terms of taking care of their teeth, that may be problematic. They may have difficulty wearing dentures. Because of their inability to properly perform oral hygiene, they may have increased caries and periodontal disease. And these conditions may be worsened by the xerostomia of the medications that they take. There may also be physical barriers and behavioral barriers that affect these patients. Oftentimes, these patients can be uncooperative. I mentioned before, they may be in wheelchairs that make it difficult to move them. So these are all considerations that you need to make with respect to stroke patients. I mentioned a moment ago in terms of embolic strokes and anticoagulant. These I'm going to go through really quickly. I'm not going to do these like diabetes and hypertension. This is me going off on a tangent, sort of, and having PowerPoint bring me back. So I'm just going to talk about stroke, which I just did. Anticoagulation, I'm going to mention really quickly. It's used, thrombus disease is one of the leading causes of morbidity and mortality in the United States. They're implicated in myocardial infarction, ischemic stroke, and venous thromboembolisms. If you remember the 1850s and you remember hearing about Virchow's triad, Virchow in 1856 described the underlying mechanisms of thrombus formation, and his triad was stasis, endothelial cell injury, and hypercoagulability. And I'm going to go through that in a moment when I start to talk about heart disease, but I just want you to remember Virchow's triangle. In terms of medications the anticoagulant medications that patients may be on, post heart attack and in the hospital, patients may be given heparin, which is actually given either by injection or IV. Many of our patients are still on warfarin or Coumadin. It was first used about 50 years ago for the treatment of thromboembolism. It was first discovered by cows in Wisconsin eating spoiled sweet liver clover. And it was separated, and that was initially used as a rodenticide. And warfarin is a vitamin K antagonist. There are other direct oral anticoagulants. Primarily the ones that are used now are factor X inhibitors and factor 2A inhibitors. And I'm going to go through the clotting cascade in a moment to remind you about where these work. You still see patients that are on aspirin therapy as an anticoagulant, sometimes in combination with some of these other drugs, and patients that are on platelet inhibiting drugs like Plavix and Brilinta. Okay, so here is the clotting cascade. So remember in Virchow's triangle, the first thing or one of the factors was injury. So you have either a tissue factor secondary to trauma or a damaged surface in a blood vessel. And you go through the cascade, and warfarin affects the function of factor 9, again, and factor 7, and ultimately factor 7. And again, this is vitamin K mediated. Then you have these medications. These are the factor 10 inhibitors, and they inhibit factor 10, and they impact the formation of prothrombin. And then the factor 2A medications actually impact the development of fibrin and actually clotting. So that is a quick reminder of the clotting cascade. Okay, so how does this affect your dental management? If patients are on warfarin, again, you may need to, and you're doing extractions or other surgical procedures, you may need to be able to determine what their INR level is. Typically in my office, most surgical procedures I will do with an INR of 3 or less. But that is also weighed on the possibility of why are these patients on warfarin? Are they on warfarin to prevent heart attack or stroke? And if I ask patients to go off of their warfarin, am I increasing their risk of heart attack or stroke? Or are there other ways of managing patients that require an INR that's greater than 3 that might impact my treatment? Do I put them on low molecular weight heparin? Do I hospitalize them? And give them vitamin K? So those are all things that might be considered in patients where it's not feasible to lower the INR less than 3. With respect to direct oral anticoagulants and antiplatelet drugs, for the most part, and there are instances where I do not discontinue these medications prior to surgery. But if I do look at someone who has bruises all over themselves, had problems with extractions or dental procedures in the past, that would require me to have consultation with their primary care physician or cardiologist with respect to altering these medications. And again, it really comes down to, am I more likely to prefer the patient has a stroke or me having to manage problems with bleeding? And clearly, not having the patient develop a stroke or a heart attack are higher concerns. Okay, so this one we're going to go back to the long form. This is heart disease. In terms of heart diseases, there were so many heart diseases that I chose to be selective, and I chose coronary artery disease, which is the most common disease to walk into our offices. And so we're going to go and talk about coronary artery disease. So it's defined as narrowing or blockage of the coronary arteries caused by atherosclerosis. And atherosclerosis is caused by a buildup of cholesterol and fatty deposits called plaques on the inner walls of the coronary arteries. Okay, and to go back to Virchow's triad, the etiology of this is damage to one of the inner layers of the coronary artery. Sorry about that. I've had this cough ever since I got back from China. In terms of how it's diagnosed, oftentimes it's diagnosed by an electrocardiogram. If patients have, if you remember the PQRS of the EKG, these patients may have either elevated or lowered ST segments on their EKG. If they've had a previous heart attack, they may show increased Q waves in some of their leads. So it can oftentimes be diagnosed with an electrocardiogram. Echocardiograms also can be used. They actually are looking for areas in the heart where there's hypomobility or thickening or damage to the walls, primarily the ventricle. Exercise stress tests are used where you get on the treadmill and they monitor you during that with an EKG and also blood pressure monitoring. Nuclear stress tests can also be done. They're oftentimes done in patients who can't exercise, they're also used in patients where you're trying to define an area where heart damage has occurred. Patients that have a heart attack or suspected heart attack, they may undergo cardiac catheterization, in which an angiogram is done, which can help identify decreased vessel lumens. And then cardiac CT scans can also be done with dyes. All right, so when I thought about this, I said, let's look at California in general, okay? And I looked at all the different counties, and let me see, San Mateo County, I think you guys are right here. And so you're actually pretty low on the scale of counties with the number of deaths related to, or the prevalence of coronary artery disease in patients. If you look at my county, Los Angeles, we're actually not doing so good. So then I went forward and I said, what is the ratio of coronary heart disease deaths? The other one was incidence, this is deaths, based on your county. So this is San Mateo County. And if you look up here, the national rate is 181.2 per 100,000 in patients that are over 35 years old, okay? The state ratio for California is 168. If you look at San Mateo, you guys are rock stars. You guys are down at the 109.4, and that's all races and all ethnicities. Clearly, there's a higher risk of death associated with Blacks, followed by non-Hispanic whites. Again, I looked at Los Angeles. Los Angeles not doing really good, okay? National rate, death rate, 182. State death rate, 168. And then the rate of all races is 198. So it actually exceeds the national rate. Again, similar profile for the distribution of deaths related to heart disease, okay? So let's talk about some of the signs and symptoms that someone who has coronary artery disease might have. When they may have chest pain, they may have shortness of breath, they may have nausea, they may be sweaty and sometimes either moist or cool, depending on what stage they're in. They may appear to be anxious. They may say, you know what, I'm really not feeling good and I've never felt this way before. Or they may have no signs or symptoms at all. Okay, so let's go back to Virchow's triangle. So you have an artery and a plaque forms in the wall of the artery because of damage. That plaque continues to form and there is further damage to the lining of the artery. Then at some point you actually may get plaque rupture that where a piece of the plaque breaks off, or you may get a blood clot that forms because of limited blood flow in this area, and then a blood clot breaks off. And that's really the pathophysiology of coronary artery disease. How is it managed medically? Cholesterol lowering drugs are oftentimes given. Patients are given aspirin. Beta blockers are used in this particular case to decrease actually beta blockers and calcium channel blockers are used to decrease heart rate and also decrease blood pressure. So what they essentially do is they decrease oxygen demand in the heart. Rentazoline is a drug very similar to nitroglycerin that is used for angina. Patients may be on nitrates, like I mentioned, nitroglycerin. They may also have sprays that they use. They may be using patches, or they may be taking pills. All of them are nitrates and just different methods of delivering them. I mentioned ACE inhibitors and ARBs in terms of lowering blood pressure, again, to decrease the workload of the heart. These patients may be on platelet inhibitors, and we talked about Plavix and the other oral medications to reduce thrombus formation. And these patients may be on aspirin in combination with these drugs as well. Okay, so how are these patients managed? Just like with the other conditions, lifestyle changes, lose some weight, eat better, watch your salt, maybe think about retiring, give payday off to a payroll company instead. Those are all lifestyle changes that will affect the long-term prognosis of coronary artery disease. Cardiac rehab may involve dietary training along with lifestyle, increase in exercise, and ways to exercise. Patients may be given medications, and I mentioned those in the slide before, what they might be given. And then there are procedures that these patients might undergo, okay? So I want to do a little bit of anatomy, just to remind you a little bit of anatomy. This is the LAD, the Widowmaker. So that's the one that's most commonly associated with sudden death associated with a thromboembolic event. The left coronary artery also gives off the left circumflex artery, the left marginal artery. And so these three arteries come off of the left coronary artery. The right coronary artery gives a branch off to the posterior descending artery, which goes off this way, and the right marginal artery. So these give blood supply to the heart, front and back and middle, okay? So let's talk about stents. So someone has obstruction of a coronary artery, and it's diagnosed with angiogram. The next thing that normally goes in is a balloon, and an angioplasty is performed with a balloon. But in order to prevent that artery from recollapsing, oftentimes stents are used. And there's two types of stents that are commonly used. The first type of stent is called a bare metal stent, and the second type of stent is called a drug-eluting stent. So in general, drug-eluting stents are preferred because they're more likely to keep blockage from occurring. They're more likely to keep thrombus from coming back. And the problem with them, though, is that they require longer-term anticoagulation, sometimes up to a year. Bare metal stents are not as preferred, but they're oftentimes used in patients that are going to require other surgery in a short period of time, and they can't be on anticoagulation therapy. So these are people that are diagnosed preoperatively with coronary artery disease, and they may need to undergo severe abdominal surgery or some other type of surgery in a short period of time where their anticoagulation cannot be stopped. Okay. And the other type of surgery is coronary artery bypass grafts. So on the right side of the heart, typically the saphenous vein is used as the bypass. And so you have blockage in the right coronary artery. The saphenous vein is anastomosed to the aorta, and that gives blood supply to the right coronary artery. On the left side of the heart, the blood supply typically comes from the left internal mammary artery. Hang on a second, I gotta plug my computer in. My apologies. The blood supply, the bypass comes from the left internal mammary artery, and that goes to to the left anterior descending artery, and the left internal mammary comes off the left subclavian artery off of the aorta. Okay. Mortality and morbidity. So morbidity is often associated with chest pain. Chest pain can be a side, or oftentimes is related to myocardial infarction. So the evolution of chest pain can cause myocardial infarction. There are also dysrhythmias that occur with coronary artery disease, and of course, with myocardial infarction, all of these conditions, death is a possible sequela. So I just talked to you about dysrhythmias, and I want to give you an example of one that you will oftentimes have your patients come in with, and just to help to refresh your memory in terms of what that is, it's atrial fibrillation. And so this is an example of normal sinus rhythm. So you have the P wave, the QRS, this is the ST segment and the T wave. The P wave is depolarization of the atria. The QRS is the depolarization of the ventricle, and the T wave is the repolarization of the ventricle. You can notice that these march along at a very even rate. You'll also notice that there's a P wave associated with each QRS, and the distance between the P wave and the QRS is all the same. So this is an example of normal sinus rhythm. So when you look at atrial fibrillation, one of the first things you notice is, where's the P wave? Because you got this kind of low amplitude wavy line as a baseline. Then you see a QRS, and you'll notice that the QRS is maybe a little bit wider than normal. Then you have this wavy low amplitude line, and then the QRS. But the other thing you notice is the rhythm is irregular. No two of these are equidistant apart. So atrial fibrillation is defined as an irregular rhythm, which means you can't beat it out just like you can like a normal sinus rhythm. So what this really is showing you is, remember, the P wave is the depolarization of the atria. What this is showing you is that the atria is not depolarizing in a normal manner. As a matter of fact, what the atria is doing, it's quivering. So it's just this bag on the top of your heart, and rather than pumping in a regular fashion, it's just shaking. And the beats of the QRS are actually, every once in a while, one of those impulses will go through the AV node and then result in the development of a QRS. The atrial fibrillation is a relatively dangerous and actually dangerous condition for a couple of reasons. First of all, blood clots can form within the atria because of that hypomobility, and a blood clot can break off. And if it's in the right atrium, it will go through the right ventricle into the lung and cause a pulmonary embolus. If it's in the left side of the heart, it'll go into from the left atria into the ventricle and into the heart and cause a thromboembolic event or a stroke. So in patients that have coronary artery disease, some of the things that you want to do when they come in is stress management protocol. These are not the patients that you want your type A treatment coordinator talking to them about their overdue bill and how we're not going to be able to treat them unless they pay it, and they want payment now. You want to try and incorporate stress reduction protocols. You want to primarily schedule them in the morning if you can. You want to try and do shorter procedures. You may utilize either anxiolytics beforehand, which is the next thing. You may want to use nitrous oxide and oxygen. Again, with these patients, you need to be concerned about the use of vasoconstrictors. How much epinephrine can I give this patient safely? There are also been shown studies that periodontitis, may have a relationship to coronary artery disease. And so making sure that their periodontal health is well taken care of, because there may be either there may be mediators that affect both periodontitis that also affect the formation of plaques in the coronary arteries. You also want to look at drug interactions. Is there something that I might give to this patient that may cause a side effect or cause a problem with these patients? I already mentioned for example, warfarin and Flagyl as potential drug interactions. Now, these patients, do they have a pacemaker? Patients with atrial fibrillation with a rapid ventricular response or a slow or bradycardia will oftentimes have a pacemaker. Does this patient have an automatic implantable cardiodefibrillator? So is this patient going to go into ventricular tachycardia, and is that thing going to go off when I'm doing treatment? A couple things about that. Pacemakers typically do not require antibiotic prophylaxis. And automatic implantable cardioverter defibrillators, if you are touching the patient, let's say in the event you're doing CPR, you may feel a slight kind of a low-grade electric shock, not significant enough to hurt you. So if you're in contact with someone while you're doing your dentistry, you may feel something, but it's not going to be anything that's going to hurt you. In addition to that, and in both of these examples, if for some reason you need to provide basic life support and CPR for these individuals, you can go ahead and do your chest compressions, and the same applies. You may feel the cardioverter go off, but it will not hurt you. And then you also have to think about, does this patient have a stent? Is it a bare metal stent, or is it a drug-eluting stent? Am I able to take this patient, or is this patient on an anticoagulant that I can stop? So those are all things that you need to think about with respect to your dental management. Okay. Emergency dental management for these patients, because one of the things that I do when a patient comes into the office and is, again, do my medical history. And then the night before our procedures, we actually review the schedule for the next day. And we review procedures. It's, we're doing a dental implant on tooth number 30, and the patient's going to be under GA. And I talk about how much medications and what medications I want to use. And then what we talk about is my staff will tell me, this patient is on this medication. This patient has this allergy. This patient has had a previous heart attack. And so what we're doing is we're trying to develop a way to prevent a problem. Secondarily, it's a way of preparing ourselves in the event of a dental emergency. So I talked a little bit about, at consultation, you do a subjective examination or assessment of that patient. What does this patient look like? Is this a patient that I'm likely to have a problem with? Again, at consultation, taking good vital signs. Normal treatment for patients who are having angina and they're hospitalized, or they're seen by the paramedics, or they're in a physician's office if it's happening. The mnemonic is MONA and stands for morphine, oxygen, nitroglycerin, and aspirin. In our offices, we are unlikely to have morphine. So we're actually going to, if we consider this patient as having a heart attack, we're going to actually do ONA. We're going to supply oxygen. If you have nasal cannula is available, it's an appropriate thing. Nitroglycerin under the tongue. Things you need to remember with nitroglycerin is you're going to need to take a blood pressure, because nitroglycerin is contraindicated in anyone who has a systolic blood pressure less than 90. So if someone's having a heart attack and has chest pain and their systolic blood pressure is less than 90, you can't give it. Also, if an individual has taken an ED medication in the last 24 hours, nitroglycerin sublingual is contraindicated. And so that's why knowing what medications your patients are on is very important. So again, for us, it's ONA. In terms of positioning, is someone who's having chest pain. There's something called the position at rest. So if you think about positions that your patient could be in, your patients could be sitting, and in the sitting position, there's less venous return because they're much more vertical. And so there's less peripheral blood going back to the heart. And even though you want to reduce the amount of work the heart does, if you have reduced preload, you may not have enough oxygen carrying supply to manage the oxygen demand in the heart. You can have them laying down completely flat. And in that case, you actually have an increase in venous return from the periphery, and that actually causes an increase in preload, and the heart has to work harder to circulate the blood, and so that may make the heart work more. I think there's a question there. Did I see a question?
Yeah. What if you can't use nitroglycerin? What can you use?
Basically, you don't have enough in your office in your emergency kit to use something, to use anything else, with the exception of possibly nitrous oxide. So if you have nitrous oxide available and the patient is not claustrophobic, it's a very good way of administering oxygen to someone. But then you can also titrate the nitrous oxide, because remember, nitrous oxide has pain-killing properties, it's anxiolytic, and it's also a peripheral vasodilator. So it's going to decrease the afterload of the heart. So it may treat some of the symptoms associated with angina that morphine might treat, which is the pain and peripheral vasodilation, and also the nitroglycerin would treat, which would be peripheral vasodilation, and the oxygen helping to replace the oxygen supply of the heart. Did that answer the question? Okay, hope so. All right, so so let's go back to positioning. So we've talked about sitting up, we've talked about lying down, and both of those are unfavorable to a patient who has coronary artery disease and who's having angina. So what you want to put them in, and I mentioned it earlier in the talk, is the position at rest. So they'll tell you, can you sit me back a little bit more? Can you sit me up a little bit more? I'm having trouble breathing. My chest pain is getting worse. So they're going to be looking for that position at rest, okay? So the question becomes, you have a patient, and let's say you have nitroglycerin in your office and it's appropriate to give it, and someone's having chest pain and they have a history of chest pain, and you've determined that by your medical history. The patient says, yeah, I get chest pain every once in a while with stressful situations, and I just take a nitroglycerin, I'm better. So from your medical history, you've determined that this patient has occasional chest pain. It's always the same, and it's managed appropriately with one nitroglycerin tablet. So your blood pressure is good, and so you give that first dose of nitroglycerin, and you kind of monitor the patient, and you kind of watch them for 2 to 3 to 5 minutes and see how they're doing, okay? So 5 minutes go by, and all of a sudden you ask the patient, well, how are you doing? Or the patient says, you know what, I'm still not doing good, and it's getting worse, okay? At that point in time, it's appropriate to give your second dose of nitroglycerin. Now, the question you have to ask yourself is, when do you call 911? My answer to that question is, I call 911 as soon as I think about it. So in the situation where you have that patient who has the same sort of angina symptoms, and they usually respond well to one dose of 911, in my mind, I'm not going to call for paramedic assistance in that patient. But if I have a patient who I've given a second dose of nitroglycerin, or they tell me that this chest pain is worse than their normal chest pain, I'm going to be calling 911 and making sure I can get help in the office. So I believe there's another question. Is that right?
Yeah, there is. What if they have their own nitroglycerin and they take it themselves?
All right, that's a really, really good question. Okay, so if I'm doing my initial medical examination and the patient says, I get chest pain like twice a year. It usually has to do when my mother-in-law comes over or when my wife wants me to clean the garage. And then what I do is I pop a nitroglycerin and I'm better. So I'm going to think about this patient. I'm going to think about that bottle of nitroglycerin. And I'm going to say, that bottle of nitroglycerin, did they get that a year ago? Did they get that 6 months ago? Or did they just get that bottle? And one of the things that sometimes patients do is they'll use the same bottle. So they'll take their new prescription of nitroglycerin and they may divide it up against with one of their other bottles. Just so they can take a bottle with them in the car or a bottle with them, to the office, so they don't have to, so they can keep that there. So this is my opinion only. I like to be able to give them the nitroglycerin that I know the efficacy is. I know that my staff replaces the nitroglycerin in my office every 6 months. So I know that if I'm going to give nitroglycerin in my office, I'm going to give what I give. There may be other providers that say give the patient their own, but you can understand the reasoning why I like to give my own. Because a dose of nitroglycerin, whether they bring it in, it's a tablet, and they bring it in from the pharmacy, or I have it in my office, it's the same dose. But like I said, I like to know what I'm giving a patient. Okay, hope that answers that question. All right. So you want to be prepared whether you call 911 for this patient to decompensate. Okay, so you're sitting there and you've given that first dose of nitroglycerin, you're sitting watching the patient, he's still not getting better, but he's not necessarily getting worse. But you want to be able to check his vital signs. You want to do that every 5 seconds. You want to check his heart rate. You want to check his pulse. You want to determine, is that heart rate regular? Is it strong? Is it weak? So you want to be able to get an assessment of this patient, because there may be a moment, and it may be the next moment, where all of a sudden this patient loses consciousness, and you need to be able to be prepared to provide basic life support and to use an AED as indicated. So in those situations, you need to start thinking the next step ahead. There also needs to be someone who's documenting what's going on in the patient in the event that the patient decompensates and requires more urgent emergency care. So let's say the patient has chest pain, and you and the patient decide that this is one that just a tablet of nitroglycerin is good. One of the things you want to do is, again, you want to check their vital signs, right? Someone in the office is going to need to document the fact that at such and such a time, with these such and such vital signs, we gave 1 dose of sublingual nitroglycerin. And there needs to be a documentation trail of every intervention that you do and every vital sign that you take. Because what's going to happen if the paramedics do come, they're going to ask for your records. And they're going to ask for what you gave, what time, what their vital signs were. On the other side of this, let's say the patient doesn't survive. You have to remember that there's the likelihood of a lawyer calling you and asking for your records and say, doctor, how did you manage this patient before he died needlessly in the emergency room in front of his wife and children? So that's one thing that you need to be able to be aware of. And so those things are all important. They also do provide information to the hospital emergency department that lets them know what you've done so that they don't have to repeat what it is that you've done. Okay, so that's all very, very important. And the last thing that I mentioned, and the oral surgery community does this more frequently because we have general anesthesia examinations in our offices, but it may be something that you may think about incorporating in your office as well. And you may think about incorporating it for conditions kind of like what I mentioned today. Someone who's having a hypoglycemic episode and you do a finger stick blood glucose and you determine, so what are we going to do in case that happens? Someone who is having a hypertensive crisis where their blood pressure goes over 220 systolic and is having a headache, what do we do in that situation? Someone who's having an MI, who is going to do chest compressions? Who's going to be doing mouth-to-mouth resuscitation? Also, with respect to doing cardiopulmonary resuscitation, if you go back to your training, there is a rhythm that you need to do it, and it's the staying alive rhythm. And remember, you do 5 cycles of CPR, and then you do pulse check, and you have an AED check. The other thing that happens at that time is there's a rotation of staff members, because if you've ever given compressions for 2 minutes, it's exhausting. And so you need to be able to, your staff needs to be able to know if they're assisting in CPR, in compressions, that they need to know that there's a rotation, and practicing that is very, very important. You can also, with drilling, kind of drill on your documentation. Have somebody there who's available to document and tell you where you are in each stage of your drill. Make sure that your staff is familiar with how to use an AED and break it out, and make sure they know how to use it. So I have to say I'm a little bit over time. Is that right?
A little bit. You could finish it up, and then we'll end it here.
Okay.
We do have one more question, though.
Okay, what's the question?
It was John Pisacani from another dental site, and he asked, how do you stay so handsome?
You know what? I actually try and emulate my idol, who's John Pisacani from Santa Clara. So thank you for the nice compliment, but it's not deserved. What I can do, if you would like, I wanted to just tell you about some of the other things I was going to talk about. I was going to talk about antibiotic prophylaxis, and I can refer you to an article. It's a Sentinel article that was written in March of 2017. I happen to have been the author of that, and it's in the CDA journal, and it's antibiotic prophylaxis for the dentist, and it's a review of the evidence. So that a lot of that information is there. It also includes some of your questions about prosthetic joints and endocarditis. I also have some discussion about osteoradionecrosis and MRO&J. And then I also talk about substance abuse. So my question to you is, I can make some of this information available or answer questions about that if the attendees want to submit questions about that, or any other thing that they may be interested in, I'll answer it. I am also willing to continue to talk if people are interested in staying on. So Ben, what do you think?
I think we need to talk to Nakia about that, because I'm not privy on how to keep it going, without a host.
We do have the ability to keep it going.
All right, there was actually a suggestion on the question I just read, and I would absolutely be willing to do another mini seminar for those that are interested. My hope is, because I think a lot of this information is important, and if you have other colleagues that would be interested in hearing some of this stuff, I recommend. I'm not suggesting that I'm a fabulous presenter, but I think a lot of this information is important. So I would be willing to, for San Mateo, to do a continuing mini lecture or recap this at another time. So that's up to you.
All right. Well, thank you very much. I think we'll get back to you on that and figure out a time and a date and we'll go from there.
All right. Well, thank you very much. Again, Nakia has my contact information and email. I can give it to you now if you want it. It's really, really easy. It's DRM like in Maranon at drmaranon.com. So if you have questions about this talk or any other questions that you might want to have answered, like I said, email me those questions and I will certainly respond to them. Okay. And I want to thank the San Mateo County Dental Society for having me as a speaker.
Yeah, we were so happy to have you, Dr. Maranon. So thanks and have a great night. We've got a lot of great feedback. So thanks again.
All right. Appreciate it. Have a good night, everybody.